So hello, for those that don't know me, my name is Jess. I'm one of the retrieval registrars. I'm also an anaesthetist in Wollongong, and I'm quite interested in obstetric anaesthesia. I was asked to prepare a talk covering some of the obstetrics related topics for the DIP Farm curriculum. We can go to the next slide. Obviously, the DIP Farm curriculum is quite large in regards to obstetrics, and so I won't be able to cover all of that in 45 minutes today, but I'm just trying to cover a few key things that I think are particularly high yield. There are some things that are more practical topics that are probably better as a demonstration, and lovely Jen Gott, one of the flight nurses, has agreed to make some practical resources for the DIP Farm candidates, which I'll work on at a later date. But this is what I'm going to cover today. So I'm going to talk a bit about practically what we would see in retrieval in our service, a little bit about general critical care of pregnant patients. I'm going to cover obstetric hemorrhage as a big presentation that we see, trauma in pregnancy, and if I have time, I'll try to cover preeclampsia as well. We can go to the next slide. Cool. So, getting an idea of what we actually see at Sydney Hems, conveniently there was a study done in the service, it published in 2013, so the data is a little bit old, but I think it's still useful to look at. Between 2007 to 2010, they looked at the number of presentations involving either a pregnant patient or someone that was immediately postpartum. There were 66 of these patients in this period of time, and they found, looking at the indications for our involvement, it was about a 50-50 split between receiving care for a primary obstetric cause or requiring critical care for another issue. So of the obstetric causes that we were involved in, the vast majority were postpartum hemorrhages, and most of these were stable. They'd had surgical control or hemorrhage control at the site and being transferred to a higher level of care. Some of these were requiring transfer to a higher level of care to achieve source control. So obviously these ones are a bit more challenging. The next most common presentations were antepartum hemorrhage, preeclampsia or eclampsia. Otherwise, we managed several patients that required critical care for non-obstetric issues, commonly acute intracranial pathology, pneumonia, trauma and asthma. Go to the next slide. So of the interventions that we provided to pregnant patients, most commonly it was supportive critical care management, bread and butter products, so RSIs, neuroprotective measures. We did perform some pregnancy-specific interventions. So in that 3-year period, there was one resuscitative hysterotomy performed. There were actually no vaginal deliveries performed by the HEMS team in this period of time. I should note here that this study was just looking at the work of GSA HEMS, not at the work done by the air ambulance fixed-wing nurses, who obviously do the bulk of the obstetrics work around the state, moving pregnant patients. And they would obviously have different numbers to us. There were 2 cases where a HEMS team needed to give tocolytics, and there were 4 ECMO transfers of pregnant patients in this period of time. This could obviously be a different number now, with ECMO being a little bit more prevalent. Go to the next slide. So the next thing I just want to give an overview of is the structure of obstetrics care in New South Wales. Obviously, New South Wales is a big place, and so we have the higher level obstetrics centres concentrated along the coastline. The way things are organised in New South Wales is we have a tier-based referral system, which is called the Tiered Perinatal Network, and we have 8 of these in New South Wales. And these are basically level 6 maternity centres at the highest level of care that's been designated to support a network of smaller centres, receive referrals from within this region and provide advice to that region as well. So these are all linked in together, and patients will move within these networks to the level of care that either they need or that the baby needs. They have to make decisions based on whether the referring centre can care for both mother and baby, and obviously this will factor into where they would need to go if they have to be moved. Another service to be aware of is something called the statewide obstetric consultation service. So this is a 24-hour obstetric advice service that is for services that don't have access to that referral network within the TPN. So this would include our service, for example. The ambulance service more broadly can contact this line to get advice from an obstetrician. Go to the next slide. This is just to give a bit of an idea about how decision-making happens regarding transfers of pregnant women or women in labour within the state. So they have this decision matrix regarding priority of transfer and who should be transferred. I won't go through all of it, but you can see here that there are several different categories. They consider whether the woman is in preterm labour, and then a number of different conditions might play into it, particularly to do with the fetal condition or maternal condition as well. And it also determines what level of escort is required. But yeah, just to give a bit of an idea that this exists. Right, we can go to the next slide. All right. So the next thing I'm going to start to talk about is just general critical care in pregnancy. As we'd all be aware, the most important thing for the outcome of the baby and for the mother is good, high-quality critical care to the mother. So there's often a lot of concern about what we can and can't do in pregnancy, and this is generally outweighed by just doing what needs to be done to keep the mum safe if that's above. What I'm going to do is start with a little bit of applied physiology. This is a topic that's covered in the curriculum. I think it's important to consider in thinking about what adaptations we need to make in providing critical care for these patients. There are a lot of physiological changes in pregnancy, so I won't cover everything. I think it would be a little bit too much for this talk. We'll just go to the next slide. So a big topic is airway and respiratory considerations. This is obviously a big source of concern and for a good reason. Firstly, we talk about there is an increased risk of airway difficulty and iatrogenic airway trauma in pregnant patients. And this is for multiple reasons. So they get this progesterone-induced mucosal engorgement and friability of the tissues that can make the airways more difficult to manage generally, but also make them quite easy to damage. They also have an increased chest wall mass and breast tissue that can make it more difficult to open the mouth for laryngoscopy or get a laryngoscope in the mouth even. A particularly concerning group can be patients with preeclampsia, can be quite edematous, and their airways can be particularly swollen. And generally in pregnancy, they found there is a higher risk of failed intubation during general anaesthesia for caesareans, which is concerning. So what this means is that we need to take contingencies and prepare for difficulty if we're intubating a pregnant patient. And these would be things that we would do all the time, obviously, like meticulous positioning. Use of video laryngoscopies become quite routine for RSI for pregnant patients in anaesthesia, and I know in our setting it would be routine. Using a short and stubby handle might be needed to get the laryngoscope in the mouth, or even taking it apart and just putting the blade in, putting the handle back on once the laryngoscope's in the mouth, and using a smaller EP tube might be necessary as well. Next major issue is quite a high risk of passive regurgitation in pregnant patients, and this is from a number of factors. They have a decrease in their lower esophageal sphincter tone due to progesterone, combined with an increase in the intragastric pressure, obviously to do with the gravid uterus, and this combines to reduce the lower esophageal barrier pressure and make it more susceptible to regurgitation. So in anaesthesia, we would do an RSI on a pregnant patient from 18 weeks for this reason. And it's a bit contentious, but generally up until about 48 hours postpartum, we would consider they would need an RSI. Obviously, in our service, everybody gets an RSI. But the thing to consider here, of course, is that the increased risk of aspiration we need to be mindful of if we're caring for an obtunded patient, or be particularly concerned about airway protection and securing airways early. These patients, if they have the potential to saturate very rapidly during periods of apnea, so during an RSI, and this is again for multiple reasons, they have a reduction in their functional residual capacity by about 25% at term. This is a combination of an elevation of the diaphragm, reduced cross-sectional area of the thorax. This is coupled with an increased oxygen requirement due to the needs of the fetus. So this is about 30% increase in O2 requirement at term. So the combination of decreased reserve and increased requirement means they just saturate very quickly when they're not breathing for themselves. And it also means that oxygen supplementation is quite important to look after the fetus. In a ventilated patient, we can have difficulty with mechanical ventilation, again due to the mechanics that I've talked about before, like higher intra-abdominal pressure and chest wall mass, increasing airway pressures. The reduction in the FRC also results in increased small airway closure with tidal ventilation. So sometimes they do need higher pressures to open small airways. And lastly, they have multiple changes in their blood gas physiology during pregnancy that need to be covered. They have an increased responsiveness to CO2, which causes an increase in minute ventilation, mainly via an increase in their tidal volumes. So it's normal in pregnancy to have a slight hypocapnia of about 30 millimetres of mercury. And this is obviously beneficial for the fetus. It favours uptake of CO2 from the fetus for excretion by the mum. The other thing to consider is just the minor thing. They have a small right shift in the oxyhemoglobin dissociation curve that affects the way they offload oxygen. So there's increased offloading of oxygen to the fetus, and this can mean that a higher partial pressure of oxygen is required to achieve the same oxygen saturation in the mum. So again, oxygen supplementation is important. A small practical point for us is because of the elevation of the diaphragm, they recommend we do thoracostomies 1 to 2 levels higher. Go to the next slide. Cool. So there are obviously massive cardiovascular changes in pregnancy. The pregnant patient sort of converts to this really hyperdynamic, high flow and low resistance circulation, which has a number of implications. So this is to do with progesterone causing a decrease in their systemic vascular resistance, along with the uteroplacental circulation, creating quite a low resistance circuit. It's also important to note that uteroplacental blood flow isn't auto-regulated, so it's solely dependent on perfusion pressure and flow as the uterine arteries become maximally dilated. The pregnancy is also a very high hyperdynamic state, and that they get an increase in their cardiac output by about 50% at the end of the second trimester. It increases a further 30% in labour, so really active state for the woman. Blood volume increases about 50% in pregnancy to about 100 mils per kilo if you had to estimate it. So this can mean that with these changes, early signs of shock and fetal compromise can be quite concealed. The increased plasma volume and arresting tachycardia can make them appear that they can make them compensate quite well for a while. A big issue is that placental perfusion can be compromised quite early in blood loss, and so they can be compromised for the fetus even if the woman's looking quite well. Eventually, they have a continued loss and a reduced ability to compensate due to a reduced cardiorespiratory reserve, and they can then decompensate quite rapidly after a point. The next thing to note is that obviously aortocardial compression is quite important from about 20 weeks gestation. They find that complete cardial compression when supine is nearly universal at term, but not all women are symptomatic with it because they develop collateral supply. But obviously positioning is very important, particularly if you're concerned about blood pressure, to do what you can to optimise venous return. So we say we would do a 15 to 30 degree left lateral tilt in pregnancy. And obviously aortocardial compression is the major indication for resuscitative hysterotomy that we do to reduce the pressure on the blood vessels and improve venous return in a cardiac arrest. We go to the next slide. So, in another important change of pregnancy is they develop something called a physiological anemia of pregnancy. This is a combined effect of an increased plasma volume of about 50%, but with a relatively less increase in their red cell mass of only about 25%. So it's normal for them to have a slight anemia, which is dilutional. They have an increased risk of venous thromboembolism, which is to do with an increase in clotting factors combined with a decrease in circulating anticoagulants. This is obviously a functional thing to reduce blood loss after delivery, but it can have the impact of creating an increased risk of pulmonary embolus from the first trimester. And also importantly for us, these patients may be on thromboprophylaxis if they're particularly high risk, so we might need to consider that in our assessment of these patients. It's reasonably common to have a gestational thrombocytopenia. It's about 8% of patients have low platelets, and it's just idiopathic and usually quite mild. And another thing to note here about hematology is there's a lot of coagulation issues that are common in pregnancy, in severe pregnancy complications. So, for example, women that have abruptions or fetal death in utero or PPHs are quite prone to DIC. Women with preeclampsia can develop something called HELP syndrome that results in quite precipitously low platelets sometimes that might need consideration. Let's go to the next slide. And then lastly, we obviously have massive changes in the reproductive system. So the uterus is the most anterior presenting organ from about 20 weeks gestation with an incredibly high blood flow for what it is. So it's about 800 mils per minute, or about 20% of the cardiac output at term. So this means that it's highly susceptible to trauma and is a significant potential cause of hemorrhage. So therefore, it's something that has to be incorporated into our primary survey of a trauma patient. So things that we would consider in examining these patients, we'd consider the fundal height for an estimation of gestation. So generally, if the fundus is at the umbilicus, that equates to about 20 weeks. A lot of the resources say that if you have a fundal height above the umbilicus, and this should mean that the pregnancy is likely more than 22 weeks gestation, and you would therefore do resuscitative hysterotomy in an arrested patient. Other things to consider is examine the uterus for signs of injury. So potentially it might be quite tender, there might be rigidity or contractions, so signs of irritability. And then also part of the examination involves an external examination of external genitalia for fetal parts called prolapse, bleeding or liquor. Okay, we'll go to the next slide. So what I want to talk about here is then how this might sort of factor in to, I guess, our considerations in retrieving these patients. Firstly, just talk a little bit about altitude hypoxia is not hugely significant for the fetus because conditions favour offloading of oxygen to the fetus, particularly those maternal respiratory changes, and also the prevalence of fetal hemoglobin, which has which binds O2 more avidly. But so altitude will be tolerated relatively well by the fetus, but not so well by the mum. So again, oxygen supplementation is often quite important. Positioning is important. We've talked about the left lateral tilt, but also practically with the sort of the gravid uterus and the big abdomen, it can be quite challenging to package patients sometimes. Pharmacology is an important point to think about. There's lots of theoretical pharmacokinetic and pharmacodynamic changes in pregnancy, and they probably don't have a really great deal of relevance. But of course, we need to consider the effects of drugs on the baby. So it can be a bit of a challenging topic. Normally, most of the drugs used in retrieval, and we say the same in anaesthesia, are very unlikely to cause any long-term harm for the baby, particularly because we're generally using them in limited or single doses, and we're providing them because the mum needs urgent care to keep her safe, and this is obviously good for the baby. There are a few drugs in our pack, for example, which have some specific cautions about use in pregnancy. So these would be phenytoin and midazolam. So benzodiazepines are said to cause cleft palate with long-term use in the first trimester, but the impact, this is all data from, same with phenytoin, these are issues from prolonged use of these drugs in the first trimester. So we shouldn't avoid using these agents, particularly in a single dose or a limited capacity if needed to keep the mum safe. I just make a note here about breastfeeding, just because this is something that comes up from time to time about, whether any changes need to be made with breastfeeding. It certainly comes up a bit in anaesthesia. There are very, very few indications to tell a mum to stop breastfeeding or delay breastfeeding based on pharmacology. Even in anaesthesia now, if someone's had a general anaesthetic, we say that they can feed as soon as they're awake enough to hold their baby. So we don't tell them to pump and dump anymore after any of the anaesthesia drugs that they've had. There's lots of really good resources around, like LactMed and MotherSafe, that you can refer to about specific drug questions before advising somebody to avoid breastfeeding their baby based on a drug that's been given. The other important consideration with caring for a breastfeeding mum is our fluid hydration. So they really need a lot of IV fluid to maintain their supply. Then another important pharmacology point is placental transfer, though. So we are obviously concerned about the placental transfer of some lipid-soluble drugs. Generally, if it's given antepartum, they're going to be metabolized by the baby, by the mother, and the baby's being supported by the mother, so it's not an issue. Where it can be an issue, of course, is if delivery is imminent. And so one example that comes up a bit is administering opioids to the mother immediately pre-delivery. Baby can come out with respiratory depression and require resuscitation. So this is where we do need to be mindful of giving certain drugs when baby's about to come out. I'll talk a bit about analgesia in retrieval. So break it up into someone that's in labour versus not in labour. If you have a pregnant lady requiring analgesia that's not in labour, we would continue to treat pain appropriately as we would for anybody else, and all the agents that we would use ordinarily can be used in a pregnant patient. The only analgesic that's really, the main analgesic class that's really avoided are NSAIDs, which we don't use in our setting. A pregnant patient in labour, we obviously are quite limited in what we can do in our context out of a hospital. We don't have nitrous, we don't have epidurals, things like that. But we can give opioids. Opioids are used on labour ward. As I said, you'd be cautious if you thought that delivery was imminent, because it will cause respiratory depression in the fetus potentially. But options for opioid analgesia in pregnancy are subcut fentanyl or subcut morphine. Are commonly used in labour wards. Antiemetics are important as well, particularly in the first trimester. They can be quite nauseous. Logistical issues that I'll go through, there's a few here. So obviously pregnancy and birth is a really sentinel event for families, and so there can be massive implications in transporting women away from their homes during time of birth. So these are things that we'd obviously have to be mindful of, and this might impact on who we bring with the lady or how we sort of organise, sort of consider where she goes or how family are going to get to her. I showed you the matrix before, so there's obviously a lot of consideration that goes into the best place both for mother and for baby in terms of transport. Generally, the indication for transport before birth is going to be that a local facility is not able to meet maternal and neonatal needs. So you have a preterm birth, or the mother is at high risk of bleeding or some other complication, or the baby has been assessed as needing extra support once it's born. We obviously in Australia need to consider very large distances as well between high-level centres and the regions. So it's often best to transfer high-risk patients early, and so generally this is done electively at about 36 weeks to a major obstetrics unit. Generally, in regards to timing, the aim is to transfer a high-risk patient with baby in utero, and to avoid having to transfer both mum and bub together or in two separate transports after birth. Sometimes it might be better to stay and allow mum to deliver at a more remote site. And these would be cases where there's a major obstetrics hemorrhage, where there's a risk to both if you don't get quick control. If there's severe chorioamnionitis, can be quite bad for the baby, and they might recommend an urgent delivery. Severe preeclampsia or eclampsia, where delivery is required for the safety of the mum, or if someone's in active labour. So in flight or in transport delivery is quite high risk. And so if birth is imminent, it's generally regarded as better to stay and deliver on the site and then transport both patients out later. But these can obviously be quite difficult decisions. The teams that are transporting these patients obviously need to be prepared for the potential that they might have to care for two patients or manage delivery in transport. And so there should be obstetrics consultation, but also a team that involves two people trained to manage a delivery and a neonatal resuscitation as well, and then a setup for that too. So be prepared for potential delivery with two sets of resuscitation equipment, a neonatal resuscitation area, warm the cabin, make sure you have oxytocin available. And then also it's important to think about just general protection for the vehicle that you're in, because obviously birth is quite a messy process, and amniotic fluid can actually damage structures. Apparently it damages aircraft, the resources say. And go to the next slide. Okay, so this is a representation of labour. The definition of labour is regular, painful abdominal contractions that lead to progressive shortening and dilatation of the cervix up to 10 centimetres. I'm just going to talk a little bit about sort of managing pre-hospital delivery, but not in a practical way, because as I said, these are best demonstrated with videos sort of showing the process of birth and also showing how you manage particular complications like obstructed labour, shoulder dystocia, breech deliveries, those sorts of things are best demonstrated. Let's go to the next slide. Cool. So preterm birth is defined as birth less than 37 weeks gestation. Very preterm is less than 32 weeks and extreme is less than 28 weeks. Management is about preparing for it. So trying to do what you can to prepare the baby for delivery, making sure they're in the best place that they can be, and then managing complications. So generally, antenatal steroid therapy will be given if bub is if they're 34 plus 6 weeks or less than that, ideally given 48 hours before the expected birth, and usually it's with betamethasone or sometimes dexamethasone. Generally, the advice is to transfer a preterm birth to a higher level of care that can care for this baby unless delivery is imminent. There are some sources in the literature suggesting not to transport if mum is more than 7 centimetres dilated. Obviously, the logistics of this involve somebody being able to assess that. So you may not have somebody there that can assess cervical dilation. And then also, practically, women are obviously very different in how quickly they progress through labour. So that doesn't always mean a lot, like being at a particular level of dilation, because it changes depending on the parity of the woman and just individual factors as well. So that's where I guess obstetric advice is particularly essential in assessing the relative risk and benefit of moving versus staying. There are risks associated with preterm delivery in the pre-hospital environment, as I've said. There's evidence that there's a higher neonatal mortality with pre-hospital deliveries, and there are maternal risks, particularly a prolonged third stage of labour and postpartum hemorrhage. There's a picture up here of something called the Good Egg Pack that Nat May was telling us about in Coffee and Cases last week. So if you're in an environment where you involved in the delivery of a preterm baby in a resource-limited setting, a lot of the smaller regional hospitals have been provided with these Good Egg Packs by the Humpty Dumpty Foundation and NETS. These contain, as you can see, quite a long list of equipment that you could use to care for a preterm baby that might not otherwise be available. So hopefully they'll be available in most places. Just another point here is with preterm births, because of the smaller size of the bub, cord prolapse is more common during labour. So something else to watch out for. We'll just go to the next slide. So an intervention that we may be expected to provide, and as I said in that with that research has been provided by this service, is tocolysis for preterm labour. So indications for this would be a woman's in labour and needs to be transported to an upgraded level of care, or to allow time for additional interventions, particularly antenatal steroids is the most common indication. But it's not used to delay labour or birth in a prolonged way. Agents that can be used are nifedipine, which is an oral calcium channel blocker. More commonly in our context would be salbutamol, which we carry in our pack that can be given IV. In the hospital, they use subcut to butylene a little bit. Giving IV salbutamol, there are some complications. There can be a risk of maternal or fetal tachycardia, and also can make the mums feel a bit unwell and diaphoretic. Go to the next slide. Another intervention to consider is managing the labour itself. So something I just talked about briefly here is the active management of the third stage of labour, which is a care bundle that is advocated and includes prophylactic uterotonics, controlled cord traction and delayed cord clamping. So prophylactic uterotonic is classically going to be 10 units IM of oxytocin for a vaginal delivery. There's some evidence that IV oxytocin is more effective at reducing the risk of PPH, and this is certainly what we give in theatre during caesareans. So it's a variable dose, but we generally give about 2 to 5 units IV. Important if you are going to give it IV to give it slowly, so no more than 5 units a minute is what's recommended, because it can make them quite hypotensive if given as a quick push. The next thing is controlled cord traction, and this is advocated if you are trained to do it, but if you're not trained to do it or not comfortable to do it, they advise you leave it out. So the way it works is you're basically assisting the delivery of the placenta with gentle traction, and you do this once there's signs of placental separation, so there's a gush of blood or cord lengthening. It doesn't necessarily reduce blood loss, but it does reduce the duration of the third stage of labour by helping the uterus to contract down. It reduces the risk of retained placenta for obvious reasons, which then does reduce risk of blood loss. So it's something that can be considered if you're trained to do it. Delayed cord clamping refers to basically waiting for about 3 minutes to clamp the cord or until the cord has stopped pulsing. This has got benefits for preterm babies and term babies. So in preterm babies, they found there's a reduced risk of neck and intraventricular hemorrhage with delayed cord clamping. And even in term babies, they found there's higher hemoglobin, increased iron stores. So there's benefits for the baby without evidence of harm for the mother. So this is something that's advocated for now. Unless the baby needs active resuscitation, in which case they won't do it. But I believe that there's research ongoing looking at whether babies requiring resuscitation can still have delayed cord clamping. That's something that might come out in the future. We just go to the next slide. So next I'm just going to talk a bit about obstetric hemorrhage. Go to the next slide. Cool. So obstetric hemorrhage is a big topic. It's the uterus, as I said earlier, has quite a high blood flow, about 800 mils per minute. So there is potential for massive bleeding in these patients, and they can get very unwell very quickly. It's divided into antepartum hemorrhage or postpartum hemorrhage. An antepartum hemorrhage is bleeding prior to delivery at more than 24 weeks gestation, including during labour. It's generally caused by placenta previa, placenta abruption, or a uterine rupture. Postpartum hemorrhage, there's a few definitions around this, but these are the ones that I've learnt from my exams and that I've seen mostly. So this refers to abnormal bleeding, which is more than 500 mils following a normal vaginal birth, or more than 1 litre following a caesarean, and within 24 hours of the birth. So it's not just immediate, it's within the first 24 hours. A major obstetric hemorrhage is greater than 1.5 litres. Can be divided into primary versus secondary PPH, and obviously primary was within the first 24 hours and secondary is up to 6 weeks afterwards. It's important to note that estimated blood loss is generally larger than what is reported. It's very difficult to estimate blood loss in postpartum hemorrhage, and particularly with large volume hemorrhage, the potential to underestimate is even higher. So management of these patients is going to be general supportive care, of course, so which is going to be resuscitation as they need, provide analgesia as they need, keep them fasted for theatre. In antepartum hemorrhage, they may consider CTG monitoring for the fetus if they feel that knowledge of the fetal condition will actually alter outcomes or by affecting the timing or mode of delivery. And if it's an antepartum hemorrhage, we consider intrauterine resus as well, which consists of left lateral positioning, oxygen supplementation, IV fluid therapy, ceasing syntocinon if it's running, if they're having an augmented labour. These are things we'd routinely do if there's fetal distress. Go to the next slide. Well, firstly, I'll just talk about placenta previa. So this is a condition where you have placental tissue extending over the cervical os. Obviously, there's different degrees of it. A complete previa, you have the os completely obscured by the placenta. A marginal previa is within 20 millimetres but doesn't cover the os. So this is often seen on the mid-pregnancy ultrasound, but it often resolves. So it's diagnosed on a 32-week ultrasound if it's still persistent. Women generally know that they have this, but we do encounter women that haven't had antenatal care that can have an unexpected previa. Classically, it causes painless PV bleeding from the second trimester, and it can cause ante, intra, or postpartum hemorrhage. The issue is that the placenta doesn't adhere well in the lower uterine segment and it might separate. Classically causes painless bleeding, as I said, which can be quite severe and contribute to preterm birth. Another issue with these is we need to consider that they may have an involved placenta accreter that I'll talk about on the next slide, which increases the risk of bleeding even further. So management of these is they need to be an appropriate level of care. They'll generally have a planned caesarean for marginal or complete previa. So they're often planned at about 37 weeks, but this depends on multiple factors. So whether they're symptomatic, their clinical background, the patient's preferences, what the ultrasound shows. So it's not quite a straightforward thing. They can commonly have an intraoperative hemorrhage during cesarean. They might need to incise through the placenta if it's anterior, and they also still have that poor contraction of the lower segment of the uterus where the placenta spins. They still have potential to bleed quite significantly even during an elective Caesar. You'd consider tocolysis for a patient with placenta previa if they've gone into preterm labour to allow time for steroid administration. Preterm birth is more common with previa patients, but you wouldn't delay delivery necessarily, particularly if the mother's unstable or there's signs of fetal distress. Go to the next slide. So I just wanted to mention here placenta accreter spectrum. So this is an issue that's commonly associated with placenta previa, and in my time doing anaesthesia, these are the worst postpartum hemorrhages that I've seen, patients that have had this problem along with previa. So this refers to pathologic adherence of the placenta to the uterine wall. There's different grades of it. Placenta accreter is invasion through the endometrium. Increter is through the myometrium, and percreter is beyond the uterine wall and potentially into surrounding tissues as well. The pathologic adherence means that the placenta is unable to separate normally and they just bleed massively. Risk factors for this are previous caesareans, so particularly increasing number of caesareans increase the number of risk of this condition. Placenta previa increases the risk, prior uterine surgery as well. So it's really important to have a high index of suspicion for this condition if you have a woman that has a previa that's had a lot of caesareans in the past. Management of these cases are, again, to be at an appropriate level of care. They can have a massive postpartum hemorrhage. They have a planned caesarean most of the time, and there's a lot of planning involved in these cases when they come to theatre, particularly with the higher grades of accreter. We obviously plan for massive hemorrhage. They usually have a general anaesthetic. We often get IR involved, so something that we can do is get them to site iliac artery balloons under local anaesthetic before the surgery that can be inflated if there's massive hemorrhage. Important with these is that they're consented for a hysterectomy before they go to theatre, because it's very common that this is what's needed to get control of the bleeding. And the ones that I've seen, they've all had a hysterectomy and that's been required. We'll go to the next slide. Placental abruption is another cause of antepartum hemorrhage. So this refers to separation of placenta prior to delivery, and it creates a condition of uteroplacental insufficiency, fetal distress, and potentially fetal death. It can cause either occult or overt PV bleeding. You can see in the pictures here how this can happen. The blood can either track down and exit via the cervical os, or it can be concealed underneath the placenta, and a fair bit of blood can accumulate here. It's classically quite painful, and they get this continuous pain rather than the sort of cyclical pain of uterine contractions with labour. And they can have quite an irritable, tender uterus as well. So this can either occur spontaneously, particularly in association with several risk factors such as smoking, cocaine abuse, preeclampsia, chorioamnionitis, and premature rupture of membranes can increase risk, or this can occur in association with trauma. It's contentious whether caesareans increase the risk of abruption. They probably don't from the last thing that I read. Management of these is, of course, supportive care to the mother, resuscitation. They need immediate delivery, particularly if there's maternal or fetal compromise. And then the other thing to consider is that they commonly develop DIC. So we need to manage coagulopathy with factors and cryo. Go to the next slide. I'm going to talk a bit now about general management of postpartum hemorrhage. So again, I make the point that estimation of the actual blood loss is challenging, and you can't rely on that to determine how you're going to manage the patient. So obviously that's done in concert with assessing the patient, their symptoms, signs, is there ongoing loss, what's the rate of the loss. Sometimes you can see that it's just really hosing out of the lady, and that's obviously very concerning. Postpartum hemorrhage is reasonably common, about 10% of deliveries in the UK. The largest ones, according to the literature, are the ones that I was talking about before, the women that have come to theatre that have got abnormal placentation and accreters. So the next thing we would do is we're going to undertake a bunch of management, and a lot of this will be directed at the most likely causes, which we can consider causes in terms of the T's. So the most common cause is uterine atony in about 80 to 90%. There are several patients that are at increased risk of poor contraction of the uterus after delivery. So these are either conditions of uterine overdistension, such as a big baby or multiple pregnancy, or conditions that are impairing the contractility of the uterus, such as a high parity, prolonged or augmented labours, the use of tocolytics, chorioamnionitis, and abnormal placentations. Then we consider the other T's, which are tissue, so retained placenta, trauma, commonly to the genital tract, or thrombin, so a coagulopathy. It's important to remember that these problems can occur together in combination, and it's not uncommon to sort of go through all the management for uterine tone, which is an issue, and still have an ongoing PPH and find an occult genital tract injury as well. That happens a fair bit. Go to the next slide. So management principles of a PPH I've just sort of grouped together. We obviously need to consider that they're in an appropriate place. So this might be within the hospital or transferred to an appropriate level of care. Broad principles are to support their circulation with supportive critical care, large bore IV access, resuscitation with blood products ideally, and then also supporting their coagulation and treating the underlying cause. Go to the next slide. So in terms of coagulation, TXA is an extremely useful drug in obstetric hemorrhage, and it's used a lot. So there was a big trial called the Woman trial, which most people have probably heard of. They looked at about 20,000 patients, generally done in resource-limited countries. They found that TXA administration reduced the risk of death due to PPH with no significant increase in adverse events in the patients. So the dose is one, as we would already give, 1 gram given as a slow IV push, and then you can give a 1 gram infusion if needed. But Woman trial was just about the 1 gram bolus from my recollection. The advice is to start it as early as possible. But within 3 hours was what the trial found, is the window that you want to give it. They're using TXA even more now as a prophylactic in women that are at high risk of PPH. So during elective or semi-elective cesarean, sometimes they're using it. So it is quite widely used in obstetrics. And then also in obstetrics, we have slightly different targets for coagulation support. So fibrinogen, we aim for a fibrinogen that's reasonably high, above 2. They found that levels below this are associated with higher blood product requirements and surgical interventions. So this would obviously be by giving cryoprecipitate or freeze-dried fibrinogen if it's available. That's obviously quite a useful product because it's transportable, but it's expensive. So it's not available widely. But I did use it a fair bit at one of the sites that I trained at. It was quite a useful thing to be able to give. We aim for platelets greater than 100, and then otherwise general supportive care for coagulation being normothermia and normal calcemia, as we all do. It's obviously difficult to assess the need for fibrinogen in our context. We might be somewhere where they wouldn't have point of care coagulation testing, and it can take a long time to get coags. So this sort of stuff is often given empirically as well. Let's go to the next slide. And then the underlying cause is generally directed towards managing uterine atony initially. So we would administer uterotonics to start with. Oxytocin is the first-line uterotonic that's given. It increases intracellular calcium. As I said earlier, it's generally given IM, but it can be given as a slow IV bolus as well, with the main issue being hypotension. Sometimes you might see a drug called carbetocin used if you're collecting a patient from theatres. This is a synthetic analogue of oxytocin. It's lipophilic and has a longer half-life. So it's a single IV or IM dose that lasts for several hours and is meant to be a substitute for giving oxytocin by bolus than infusion. And it's been found to be not inferior for prevention for PPH. Agometrine is the second-line agent used for PPH. So this has multiple receptor effects that you can see here, but they're actually uncertain how it acts on the uterus. It's not a good transport drug, so it has to be refrigerated. It's prone to degradation, but it's very useful for PPH. It's quite effective. It's a bit of a dirty drug. It makes the patients feel really rotten when they're awake, so it's really emetogenic. and they get very flushed. So we give them what the Vaniomedics if we're giving it, and we give it very slowly too. It can be given IM or at a reduced dose IV, given slowly. The big issue with this is it can cause hypertension, so we have to be quite cautious with it in patients that have heart disease or hypertensive disorders of pregnancy, and it's generally avoided in these cases. Other drugs that might be seen for PPH management, misoprostol can be used in resource-limited environments, but you wouldn't really see it used much in a major centre for this at all. Carboprost is PGF2 alpha that's being used quite a lot in theatres now. It's given either IM or intrauterine. This one is, the main issue with this drug is bronchospasm, so we try to avoid it in asthmatic patients. It can be an issue. Let's go to the next slide. So then it's about, I think they say about 1% of PPH cases are refractory to pharmacological management and sort of basic basic non-invasive measures like external uterine compression, like uterine massage, and then require further invasive measures. But just to cover here, that the general non-invasive measures that would be undertaken when a PPH has begun would be a firm uterine massage. And so this aims to contract and shorten uterine fibres. The way it's done is you sort of feel a boggy uterus and massage it firmly and helps them to contract. They can tell that it's working as they might expel clots and the uterus will feel firmer. It's quite a painful thing to be done, so it's important to warn the woman that you're going to do this. The next step from that is bimanual uterine compression, and this is a bit limiting because once you apply it, you have to stay in place. But that's the next thing to do if uterine massage isn't working and you're trying to get control of bleeding. You obviously would apply basic pressure to areas of trauma and bleeding that are external. Invasive measures that might be considered. So someone will need to go to theatre for removal of retained placenta. This generally needs to be done under anaesthesia, so it has to be done in an operating theatre. Something that was being used a lot now is balloon tamponade, like a Bakri balloon. So this applies hydrostatic pressure on the radial arteries of the uterus. It's used for refractory bleeding. It stays in for about 4 to 6 hours, and beyond this there's an infection risk. And importantly, once it's in, we don't take them out until they're in a safe place because they can rebleed. Uterine compression sutures are used sometimes in theatre if the woman's had a caesarean. Interventional radiology is very useful. As I said before, it can be prophylactic, so the iliac artery balloons, or it can be done as an emergency, so uterine artery embolization can be done for an acute PPH. And then lastly, the last measure is a hysterectomy. This is the last resort and is done to save the woman from a refractory PPH. Go to the next slide. I'm just going to talk a little bit about trauma. So trauma is uncommon in pregnancy, but it does happen. And there's several issues with this. There's a higher mortality rate for pregnant women undergoing major trauma. And there's a reasonable, the fetal mortality in major trauma was estimated in one resource that I saw at about 50%. So that's really significant. This is mostly, the fetal mortality is mostly to do with placental abruption. The most common mechanism is blunt trauma in pregnancy. And the issues are they get a traumatic APH due to abruption or uterine rupture. So obviously we've gone through a lot of this already. The principles are much the same. We need to be mindful of these physiological changes in the pregnant patient, and which is going to involve making sure they're getting enough oxygen, being aware that they have altered cardiovascular system compensation. So something I read said that pregnant trauma patients can lose up to 35% of their circulating volume before they exhibit signs or symptoms of hypovolemic shock. So just having that really high index of suspicion in a pregnant patient about how they'd be compensating. And then also including the uterus and external genitalia in your examination. A woman that has PV bleeding in the context of trauma is always concerning and should be significant. An antepartum hemorrhage, a major antepartum hemorrhage, is defined as more than 50 mils of PV blood loss, so that's not very much. We'll go to the next slide. So general trauma care is going to be principles we talked about before. It's important for them to have supplemental oxygen and early airway management because we're anticipating difficulty and they're at higher aspiration risk. Important is to manage aortocarpal compression. So basic things are making sure we have IV access sites above the diaphragm, as we always try to do anyway, and also considering how we're going to apply mechanical displacement of the uterus. And so some of the options that are suggested are to have the patient on a spine board and wedge them that way, to have a wedge or personnel underneath to apply that tilt, or you can apply manual displacement, as you can see in this picture here. This obviously requires somebody to do that and hold that position, so it's a bit challenging. We need to consider as well other circulatory support. So it's important to maintain uteroplacental perfusion. As we talked about, the uteroplacental unit is flow dependent and so it's quite susceptible to hypotension. So some resources suggest to maintain a systolic blood pressure above 100 for pregnant trauma patients, just to maintain that perfusion. We obviously minimise crystalloid resuscitation, which could worsen the physiological dilutional anemia of pregnancy, and use early blood product resuscitation like we do with all of our trauma patients. TXA is useful for trauma and for pregnancy if you have it, so we should give it. We had a discussion in Coffee and Cases last week about the use of pelvic binders in pregnancy, and the consensus in the group was that the access binders that we have, the main issue with them is that they don't fit in the second and third trimester, so they can't be used in that time, not necessarily that they're contraindicated. And so in the group we were discussing that if you had a pregnant trauma patient with an obvious pelvic injury that you were concerned about and wanted to bind, then maybe a sheet would be more appropriate. This might be a good, if anybody has any other ideas about this, to put on the WhatsApp group. That was the consensus that we came to as a group last week. Let's go to the next slide. And then my last topic, sorry, I know. I'm just going to talk quickly about preeclampsia because this is just another reasonably common presentation. It can be very significant. Most of the time it's been detected, but we've got to be cautious of women that haven't had a great deal of antenatal care that might present in severe preeclampsia or with complications. So you can see here that preeclampsia is a definition that it's hypertension with proteinuria or edema above 20 weeks gestation, and the blood pressure parameters are listed there. Severe preeclampsia is where we might be more likely to be involved, and this is women that have a systolic blood pressure greater than 160 or a diastolic greater than 110 with signs of end organ dysfunction, including HELP syndrome. And obviously the end organ dysfunction can be quite diverse, and sometimes this can be what they actually present with. It can be renal involvement, it can be CNS symptoms like hyperreflexia, clonus, headaches, visual disturbance. They can have respiratory problems like APO, hepatic dysfunction, hematological problems, and then HELP syndrome refers to hemolysis, elevated liver enzymes, and low platelets. And the platelets can become precipitously quite low. Risk factors for preeclampsia are primate, smothers at extremes of maternal age, a personal or family history of the problem, certain pre-existing diseases like hypertension, diabetes, molar pregnancies, and multiple pregnancies. Let's go to the next slide. And just lastly, a little bit about management. So what we want to try to do is control their blood pressure, prevent and treat seizures, and then provide supportive care. Controlling the blood pressure, we don't want to drop it too quickly, so generally we aim to lower the MAP by about 10 to 15% or less than 140 on 90. If it's in mild, moderate cases, they'll use oral agents as first line, so nifedipine and labetalol. If it's severe, they often need IV treatment, or if they're coming to theatre, we'll try to bring it down with IV agents, being either hydralazine or more commonly labetalol now. If a pregnant woman, if a preeclamptic lady has a seizure, she obviously has eclampsia, and that's treated with magnesium, so a 4-gram IV bolus over 5 minutes. There was a trial called the MAGPIE trial that found that in women that have severe preeclampsia, especially if they have neurological signs as well, there's a benefit in preventing seizures by giving magnesium prophylactically. So these women will get that 4-gram IV load over 5 minutes and an infusion of 1 gram an hour for 24 hours. Just to 4 grams of magnesium is about 16 millimoles, so it often sounds like a lot, but it's actually not that not that huge amount, but they do need to be monitored for high magnesium levels. If they get recurrent seizures, we give further boluses of magnesium, so another 2 to 4 grams. And the other things to mention about these patients is supportive care is a little bit different. So as I said earlier, their airways can be a little bit more difficult and a bit more edematous, so you might need a smaller tube. And it's also quite important to, if you're intubating the patient, to manage the pressor response to laryngoscopy. They can develop quite a significant hypertensive crisis with laryngoscopy. So these are situations where you would certainly try to give drugs to not let the blood pressure go up too high. And this might include opioids. So in anaesthesia, we commonly use alfentanil or remifentanil. We would use esmolol, magnesium, or lignocaine, other agents that might be used with an induction to stop the blood pressure going too high. They can have quite challenging fluid balance. So they have a condition of relative hypovolemia, but they're quite susceptible to APO due to increased vascular permeability. So you have to be quite cautious with fluid resuscitation in these patients. And then lastly, they can be at an increased bleeding risk because they're at high risk of developing a coagulopathy. So they might develop thrombocytopenia or DIC. I think that's my last slide. Is that it? Yep. Awesome. These are just some of the resources that I looked at. Thank you, everybody. And thanks, Chris, for doing the slides for me. I'm sorry I couldn't get it to work.
Oh, that's okay. Sorry it didn't work if it was on our end.
Yeah.
That was awesome, Jess.
Thanks, Chris.
Plenty of practical pearls there. Round of applause.